mental health. We're getting started with the first of a series of small county meaningful use webinars. In a few minutes, Thad Dixon from XPIO Healthcare will be taking you through some of the important considerations and issues facing small county mental health and behavioral health agencies at this time related to meaningful use. But first, a few housekeeping things. You are all currently muted. Thad will be pausing on a regular basis to ask for questions. So if you want to ask a question, you can do so by typing it into the question box, or you can click the hand icon next to your name, and that will alert us to take you off mute so that you can ask your question. I just, a few minutes ago, sent out the PowerPoint for today's webinar through email, but if you didn't get them, please either type me a request in the question box or send me an email. I'm at S as in Sam, Z as in zebra, ATZ @CIMH.org. And just to let you know, this webinar is being recorded and will be posted on the CIMH website soon, in the next couple days. You'll receive a link to the recording when it's available. We don't have the next Small County Meaningful Use webinar scheduled yet, but we are planning it for early November, and we'll let you know the details as soon as we have them. So at this point, take it away, Thad.
Well, great. Well, thank you so much, Shoshana, and welcome, everyone. Thanks for attending here. I see the 24th person just joined, which is, I believe, how many we had scheduled. So it's great to have you all on. So the course here that we're going to walk through is basically the meaningful use for mental health organizations in the state of California. We are beginning at the beginning, and we are going to look at AIU in approximately 1, 2, 3 steps. As you'll see, there are a few sub-steps to those, and as many of you may already know, there are some complexities, in particular in the state of California, related to meaningful use, and we will get into some of those as we walk through. Because this is Course 1, the objective here is to explain clearly the Medicaid Acquire, Implement, Upgrade path to registration, attestation, and completion, which will result in your incentive dollars in very clear and fundamental terms. So if this course, for example, has things in it that you don't understand, that don't make sense, that's the point at which please raise your hand and ask a question, because this is the first in 6 courses, and these courses will get increasingly complex as we move into stage 1 and stage 2 in the meaningful use process. So we are assuming that the group here today is just beginning out on their meaningful use journey, and therefore I do encourage questions and look forward to interacting with you all as you have those. So Shoshana, are we ready to go?
Yeah, one person has raised her hand, so let me just check. Linda Bill? I have you off mute, Linda. Do you have something you needed to say?
No, I'm not sure why.
Okay, I'll take you off.
Not yet anyway. I'm sure I'll have questions by the end.
Okay, thanks.
Thank you.
Great. Well, thank you. That's a great way to actually show how, if you have questions, you can immediately have your hand raised, and Shoshana will put you off of mute. So with that, we're going to jump into Meaningful Use 101. Because this is a CIH course, we do have some specific learning objectives, and really what we want to focus on in this course is the understanding of the Medicaid AIU, or Acquire, Implement, Upgrade program, and specifically as it relates to mental health organizations in California. We also want participants to be able to navigate the CMS, or Centers for Medicare and Medicaid Services application process. And we do want them to be able to navigate the group proxy calculation, as well as some components of the Medi-Cal application. So we are going to get into basically the CMS overview and application process, and then we're going to get into the Medi-Cal application process, which includes calculating your Medicaid volume, which is a part of the requirements of meaningful use. But in order to start out, we want to build a little bit of an understanding here of what we're doing. And what I really like to start out with is letting you all know that for the most part, you're most likely qualified at the end of this journey. So, we first want to make sure that you do have a certified EHR, and if you're using one of the several different systems that our previous analysis of technology in the state of California amongst the counties at least is accurate, most of you will have a certified EHR. And then you do qualify as organizations via eligible professional. As many of you may know, behavioral healthcare organizations themselves were not identified as the institutions that could qualify. But there is what we essentially will call a workaround for establishing eligibility to your organizations. You do also most likely have adequate group volume, which means that your agency themselves, if you look at the total number of services that you provide, you will have at least 30% Medicaid volume. And again, most of you know that in the business lines that your organizations provide services in, you have typically 70, 80+% of Medi-Cal enrollees, Medicaid services, as meaningful use calls it, within your practice. You can start in 2013, and in fact, it is not too late as of right now to begin the AIU process for 2013. And for organizations that do that, you can receive $21,000 per EP, which is eligible professional in year one, or a total of $63,750 over the 6 years of the program, which do not have to be concurrent, but can't start later than 2016. And we're going to look at the timeline here in a few. So this is the place at which really we start, and for all of you, hopefully these conditions most likely apply. And yes, it's going to require some effort. And, we do this for many organizations and see many organizations get on this road. And it tends to always be worth it, not just for the economic value, but also for the streamlining and utilization of your EHR and your technology and your strategic environment within your organizations. So with that, let's jump in and talk about what meaningful use is and how we're sort of going to take you through a trajectory of meaningful use for your organizations. Now, in order to get efficiently through this webinar, I have gone ahead and made some assumptions, and there are several different paths for meaningful use. And in fact, those multiple paths, in our experience, can make it kind of overwhelming to know where to start. We're sort of pre-simplifying that for you all, and we're taking you through a particular course, a particular trajectory in meaningful use. And I'll try to touch on those assumptions that we've made. And most of those assumptions should map to your organization. So one of the first things to mention is that the Meaningful Use Program does apply to both Medicare and Medicaid. We are going to focus on the Medicaid side of the program, and with that, we have the particular advantage of being able to start under what's called the Adopt, Implement, and Upgrade provision. That is what we and all of you can do in the first year of the program. And this is what enables us to essentially go through an expedited process. It doesn't require that you have your EHR system actually fully implemented. And it doesn't require that you have all of your meaningful use workflows completely figured out. but it does require that you have a certified system. And this is essentially the benefit of the Medicaid program, in that they will offer in this program $21,250 per EP without having to submit the data collection requirements that fall under the next year of the program, or they fall under the first year of the Medicare side of the program. So assumption one, we are going to focus on the Medicaid program. In this Medicaid program, we have to, as I mentioned, deal with the workaround, which is that your psychiatrists, your MDs, your nurse practitioners, ARNPs, they need to reassign the benefit of the EHR incentive program over to the group. And there is a particular set of steps and processes that we like organizations to cover in this environment in which your EPs, or eligible professionals, are going to reassign their benefit to your organization. So while I have this screen up, and I'll let you look at the Medicaid side, let me just pause and see if anyone has questions on the reassignment of benefit process. And I am going to cover a few other nuances of it in the state of California, but I want to also allow an opportunity for people to ask questions at this juncture, because there typically is some considerations for the reassignment of benefit.
Thad, I don't know if it's just me, but right now on the screen, we only see the introductory slide.
Okay, let me make sure the screen is resolving. So did it stick on that first screen?
Now I can see the chart.
Okay.
And there are no questions yet.
Okay. So let's look at the timeline, assuming that we start in 2013. And let me ask this question, and because I want to cover an exception in the year 2014. Have any of the organizations or groups that are on the line right now achieved AIU at this juncture? And we don't need, just if you raise your hand, sort of as a show of hands in the presentation, I can have an idea if this applies to anyone.
People are raising.
Then I'll ask Shoshana for you to.
Yeah, so far 4 people have raised their hands.
Okay. So I want to address the 4 organizations that have done the AIU phase, of which what we're covering today will be something you're familiar with, and I want to make sure that we also let you know as organizations that 2014 has an exception in that typically you would have a 365-day reporting period in 2014 if you were in your second year of meaningful use. And in 2014, there is a one-time regulatory exception that allows organizations to have a 90-day reporting period. So in other words, if in 2013 you did your stage 1 reporting for the first 90 days, you get to do another year of reporting under stage 1 for 90 days. And that's where this chart here, if it happens to be your full year of meaningful use in year 3, you actually would only need to do 90 days. And that gives organizations a big advantage. So if you are AIU in 2012, it is a real advantage in 2013 to try to get your 90-day reporting period established. And being October 2nd, it's actually essentially the last day that starts that 90-day period. So I would encourage the organizations on, if possible, to begin their stage 1 reporting right now. And that will enable you to do another 90-day reporting in the first quarter of 2014, which essentially allows you to double up on the economic value of your incentives. Now, that doesn't necessarily apply to the other organizations, so I'll shift back to the AIU. So one of the first things that organizations evaluating whether or not to go down this economic road is what we just sort of look at as and call the eligibility analysis, or the should we bother. And there's a couple of different reasons why I think it's worth bothering and why CMS and Medi-Cal think it's worth bothering. But for one thing, we do need to establish that you're actually eligible if you're going to implement a meaningful use program. So there's a few different things that it helps to analyze, and I want to cover the areas that I usually see organizations get tripped up. Basically, we do want you to validate that you have a certified EHR. You know, that's your IT systems overview. We do like to look at if you have other competing objectives, if you're doing a joint commission certification, you know, any number of other organizational initiatives that might affect your timing and your resources. And where I see the challenges usually in really just the administrative process is for your eligible professionals, do you have their PACOS system information, which is their identity and access, login and password information on file? And do they have NPIs established at Medi-Cal? And do you have a way to calculate volume in your EHR system in a way that can document that your facility is eligible? Because even though you may know that your organization does at least 30%, we still have to prove that that volume is adequate per the state regulation. So we essentially look at these 8 steps, getting these pieces of information organized when we start out. Looking at your programs and how your NPIs are structured, that's one thing that's important, because when we calculate the group volume proxy, we need to know how many different NPIs you have floating around your organization and how you're going to approach calculating those different locations and or programs, because the regulation states that you must not limit the scope of your practice when you calculate the total encounters for the Medicaid volume. And we're going to cover that in the state of California here a little bit. And then just the other logistics is that if you have multiple NPIs, we like to look and see how are your individual doctors and nurse practitioners associated to those NPIs. Typically at the state, there's a domain mapping exercise that we look at which NPIs have which facilities that they bill under. And that helps us ensure that when we pass these applications from the federal CMS site over to the Medi-Cal state level registry, or FLR, that we can find and achieve an NPI match between those two databases. Another good question to ask people is, as we're looking at enrolling them in the programs, have they been enrolled in a prior EHR incentive program with a previous employer? This program has been going on since 2011, and so oftentimes new hires or people that may have come over from other organizations may have already initiated their meaningful use under another organization's NPI. Now, oftentimes the question comes up, well, can they switch over to your organization? And the answer is yes. They can switch over if they did Medicaid AIU at a previous organization, then that practitioner can switch over to your organization, with the caveat being they'll switch over in their first year of stage 1 90-day reporting. So if your practice isn't yet at that stage of meaningful use, that provider will have to wait until your practice basically catches up, because you can't get AIU twice, nor can you get any year twice underneath meaningful use per each individual EP. All right, any questions on that?
Doesn't look like it yet.
Okay. So essentially what we look at as your organization gets established in their program is an estimate, as we mentioned, 10 EPs in the first year will equal 212,500. And if you cut that in half, 5 will equal 106,250. So as we, as you work with your internal staff, and as we work with organizations looking at what their potential economic benefit is, typically it makes sense to sort of hedge your bets on this, if you will, and look at how many you think you have, and then how many you think will truly be eligible and sign over the benefit to your organization. And with a lot of individuals that may have multiple groups, this tends to be sort of a first-come, first-serve paradigm when you're approaching your practitioners about the reassignment of benefit to your clinic. So essentially you have what's potential and you have what may be likely, and all of that just depends on your group, your practitioners, and what the environment is. If your group is all staffed with full-time MD or nurse practitioner employees, and you know that they've been with you for at least 3 or 4 years, then, provided they have the correct credential, then there's not going to be much of a question that all 10 would be valid. All right, so let's jump into where we have to actually start to do the registration process. So let's assume that you are in charge of getting 10 eligible professionals registered and set up at CMS for meaningful use. What do you do first? Well, one of the first things that need to be done is what we call the reassignment of benefit statement, and I covered that a little earlier. What we like to do is have, for the audit file, individual EPs physically sign the CMS registration disclaimer form and a state-specific form that gives a third party the written authority to actually complete the registration on behalf of the eligible professionals. So I mentioned earlier that we're going to sort of assume that we take a particular path through the registration process. You can have your individual EPs go on and sign up for meaningful use and complete the registration on their own. That's certainly an option. We have found historically that organizations don't have the highest success rate with that option. And so what we're assuming here is that the reassignment of benefit and third-party registrant process is going to be the most effective. So I'm curious, out of the 4 organizations that have gone through AIU, how many of those used a third-party registrant to complete the CMS registrations for their EPs?
And while we're waiting for the hands to be raised, there is a question. What is the benefit of applying through a group?
That is a great question, and we are going to cover that. What I want to distinguish here is when you sign up at the CMS site, you don't actually yet have to choose whether or not you're going to necessarily do a group proxy calculation or sign up under a group versus doing that application individually at the state. But there is a choice you have to make at the CMS application related to reassigning your benefit to the group, right? And so there's a distinguishing point here, is that to complete your application at CMS, at the federal site, you do need to put in the NPI and the tax identification number of the group to whom the EHR benefit is going to be reassigned. This is different than choosing at the state level to use either an individual versus a group proxy calculation. And back to the question, I think it's a good time to actually answer it, is that the benefit of having your EPs assigned to the group, there are several, and doing a group calculation and using a group or a clinic model within the Medi-Cal SLR. So let me just cover why it is that it would make sense to use a group when we get to the state application versus doing the individual. First off, with a group, you can utilize the entire group's volume calculation and do one volume calculation to which all of the participating EPs can then be associated and used. If you do the individual model, you'll need to run a volume calculation for each individual, which will be unique and different from person to person. And what that also will affect is that the group themselves, or the individual, I should say, themselves, may have less than the required volume, and therefore it could cause one of your practitioners to not be eligible. Where if you use the group, as long as you establish the group eligibility as a whole, each and every EP that works for that group, regardless of their individual volume being above or below 30%, they will qualify. It also is an advantage when you hire new eligible professionals into your organization or your practice, because those EPs on their first day of work will understandably not have any volume with your practice in the previous calendar year. But if your group is established already as having adequate volume, and if the newly hired EP sees Medicaid clients, that is a caveat, or Medi-Cal clients to be specific, then that person is immediately eligible by being able to inherit the group's last year's volume calculation. So that person can essentially qualify for the AIU in the first day of employment, as opposed to having to wait 365 days until they have a volume in the previous calendar year so that they can then complete their application. So that's probably one of the bigger benefits there. Now, if your group themselves is below the 30% threshold, that's when it makes sense to then look at individual volume. Because if you have 10 individuals, your hope would be, well, the group isn't eligible, but maybe 2 or 3 of the individuals are. Okay, so when we're going to move through this process here, the first thing that we really want to do is what's called the access request process. So the access request process at the federal CMS site is what allows a third-party registrant to essentially act as a proxy for the eligible professionals that we are going to be filling out the application for. And so remember, because there is this sort of interesting workaround that we have in behavioral health, you don't have institutional eligibility, in other words. You have EP by EP eligibility. And that EP by EP eligibility means that you do your applications EP by EP. So you've got 10 eligible professionals, you have 10 eligible professional applications at the CMS site. So there is really no way to do a group at CMS, right? You're just going to do 10 applications, one for each of the EPs at your organization. And the way we do that is we send those eligible professionals an access request through what is called the I&A system. So another one of the assumptions that we have to make here is that somebody in your organization, or that you're working with somebody, has an identity and access account set up at CMS that they can utilize to then associate the other practitioners to themselves, as it were. So with that, the person with the existing identity and access account that's going to do these applications logs in to their INA account, which they would have got when they registered their NPI or signed up for the identity and access account, and navigates to the access requests component in that website. And then via the add access request process is going to actually send via the NPI of the practitioners an access request to that practitioner's account. Okay, so this is essentially the preliminary step to getting those, let's go back to our number, our hypothetical scenario, to get those 10 EPs set up so that you, whoever is the third-party registrant here, can actually complete those access requests. So what you'll need is your own identity and access account, and then you will need the ability and the permission from the provider whom you're enrolling to sign into their account and approve the access request. So what you see here is now a view of us jumping over to the individual EP's account, sending that, having sent that rather from, in this case, our account. And now they can click on that request tracking ID box. And what that'll do is it will connect the EP's account to the third party's account and allow that then application to show up in the EHR registration and attestation system. So our Jane Doe here, once we have approved that, once she has approved that access request, is going to show up now in the CMS registration container, and we can begin that registration. So let's take a pause there.
There is a question that came in a few minutes ago. Does this mean we can apply for AIU for newly hired EP in years after we do our AIU for the rest of our EPs?
Yes, you can. And what you will have as you move through the years and the trajectory of this program is you may have different EPs in different years of participation. And that can require some management. But the short answer to that is yes. Even if, the previous group of 10 all did AIU, your newly hired EP can come right on board and you can go right to the AIU incentive benefit for that person. Okay, are we good for questions, Shoshana?
We're good. Oh, wait, hold on.
Okay, so great. So once you are...
There is another question. Just a sec.
Okay, great.
Is that only if you registered as a group?
Not necessarily. And by registered as a group, I presume the person who's asking the question, and the name of the person asking the question so I can address them.
Belinda Espino.
Okay, Belinda with a B? Or?
Yeah.
Okay. Yeah, Belinda, great question. At the state level system, if you don't actually have to have registered as a group in the previous year, but it's probably a good idea to convert your SLR registration over to a group when you add the new EP to it, if you're going to be, having that person associate and use the group's volume. And the main reason is that, the person themselves who you're hiring, it could be hard to get their individual volume from that 90-day period in the previous calendar year, right? And that's where the volume has to come from. So it's going to be easier to attach new hires to your group if you set up the group or clinic at the state system. And you can do that even if previously you'd set them up as individuals by calling Medi-Cal and talking to Renee or someone there who's, fluent in the system and knows what you're trying to do. You just call and say, hey, I did, individual EPs, and I'd like to change it over to a group. And they can, basically they have to switch the database over to allow that. And there'll be some setup you have to go through.
Another question, what does AIU stand for?
Oh, and sorry, I probably skipped over saying that. It stands for Acquire, Implement, and Upgrade. And that is the provision that allows y'all to basically get that first year incentive money for the early stages of adoption and not having to actually report any data under the stage 1 requirements to the state. Now, obviously, the applications that we're doing, there is data that we're collecting, there's information we're putting in here, but the only real data that we're establishing under the AIU phase is the calculation of Medicaid volume and the documentation that you have a certified EHR and that there has been, essentially an economic transaction between yourself and the vendor to achieve or, to prove to the state, as it were, that you actually bought a certified system.
I think we're good.
Okay. So there are several steps at the CMS registration. If there are some individuals that want to walk through that in more detail, I have some particular presentations or screens that deal exactly with that. It's relatively straightforward. I typically find that the hardest part of this process right here is getting the third-party registrant set up, because you have to essentially locate your EPs, find your passwords, find their passwords, as it were, get permission for you to approve the access request. And then once you get the eligible professional into your CMS registration account, then registration, you just really need to know the NPI and the EIN of the clinic that you work for or that the EP is reassigning a benefit to, typically the same. You don't technically need to have your EHR certification number yet. If you do, it's fine to put it into the federal system. And there is actually on another program, a benefit to that, because there is basically a Medicare e-prescribing penalty that your organizations, if you do Medicare Part B, are subject to. But if you're participating in the Meaningful Use program, you're exempt. And the way that the Medicare ERX program knows that you're participating is that you have a certified EHR ID number in your meaningful use federal application. That's sort of a bit of a, trick, if you will, to abate that Medicare ERX adjustment penalty. That's a 1% escalating adjustment over the next 5 years. So just FYI, if you want to avoid or if that penalty applies, go ahead and put that EHR certification number in your federal CMS application. From there, you're really just going to move through the screens and the steps. There's three application components. You can get that filled out by just following instructions pretty straightforwardly. So what that then will do is once you complete that registration process, that will send the application down to the state Medi-Cal system. And this is where there's some of the choices here that we need to make related to groups versus individuals. So we're now, after about a 24-hour period, going to be ready to initiate our state applications. So this particular component here of the presentation does get a bit, more detailed. And there may be some follow-up that you all want related to this. So, there's several hundred pages of manuals that relate to this. So again, I try to distill it down to a particular set of assumptions in a particular course. But you may all have some questions or want some information. Feel free to ask that. So what we're going to look at is what is referred to as the express attestation model within the state Medi-Cal SLR system. So essentially, there's three ways that you can do an application within the state level registry, and that's the SLR. The NLR is the national level registry, which is the CMS registration component we just looked at. So what we're going to, though, focus on is the group clinic representative. Okay, and so we're back to the question that Melinda asked. We're going to be looking at setting up your practice from the very beginning with, a representative that then essentially is going to be able to associate individual eligible professionals back to that group. So let's focus on, and actually there's a couple of things down here at the bottom I do want to point out. There is a delegation of authority form that you do want to have your EPs sign for whoever is acting as the group representative. And that can be somebody in your clinic, it can be somebody out of the clinic, but it just has to have somebody who is essentially authorized by the individual eligible professional and by the organization through contract or through some other mechanism to complete the application on behalf of the EP. So with that delegation of authority form in hand, and with the reassignment of benefit that we talked about earlier in this national level registry process, right? You have now the prerequisites in place from essentially an audit perspective that enables you as the individual to move forward with the attestation process and the application completion process at state. So in the state level system, we're going to create the account first. And the account that we're going to create is actually the group account. Now, as some of the organizations on the line are familiar with, there is, of course, a way to create individual accounts and to do this EP by EP or eligible professional by eligible professional, but we're going to start with the assumption that we do the group clinic representative. So the way that you would set up that account, if you haven't already created them, and if you have, you do actually need to call and get this switched over. But here, what we would do is create an account at the SLR system and choose the group clinic representative as the role. And this will establish that account. And remember, we also have, in our scenario, 10 NPI'd eligible professionals sitting with pending applications in the state level registry now, right? Because we already did the federal registration process. So once you create that group, you're going to now have an actual group container here. And that's essentially the way that we're going to be able to establish the group here is we're creating a container underneath your practice to which we'll now manage providers in the group. Any questions on that?
Not yet.
Okay. So after the group is established, this is where you're going to have a delegation of authority set up, and what we need to obtain at this point is the account information at the Medi-Cal system for each of the NPI'd practitioners that are participating in the program. Okay, and so really what's going to happen here is that once you've established the group, you're still going to have to go into the individual accounts of the EPs and complete their application, registered or logged in, I should say, as that provider. This is the form that gives you the authority to do that. Now, you know, Medi-Cal certainly wants to make clear that your eligible professionals, they don't have to delegate authority. They are certainly entitled, if you will, to go into both the CMS and to the state SLR Medi-Cal system and do these applications on their own. It is a fair bit of work, and that has historically been something that the individual EPs haven't had time nor interest in doing. And we have found, as long as the process is explained clearly, that there's not typically an issue with those professionals delegating authority to a third party to walk through the register or to do the registration on their behalf. And there is an important thing to remember as well. The eligible professional is reassigning the benefit economically of that program to the organization. But it is the organization's purchase of the EHR and investment in that electronic health record system, which has essentially made the incentive program a viable option for the organization to pursue. Typically, at least in the context of your group, that EP has not participated economically in the purchase of the county's EHR, although that eligible professional certainly participates in the collection of data and the information and the work that you all perform there as a part of your duties. But really, in this, unless that EP has their own private practice, and unless that EP has a certified EHR at that private practice, and unless that EP goes through the steps that we're talking about right now, this incentive benefit is not inherently available to that EP. So the next thing that we have to do is establish the group volume. And again, a lot of these are concurrent activities when we begin the process of starting, to collect information for the program. But back to establishing the group volume, what we want to make sure that we do is have the ability to generate defensible reports, if you will, and to do that consistent with what the volume calculation model is. And at the high level, it's relatively straightforward. Essentially, and they did update this in 2013 and actually made it a little bit more, accessible, if you will, to organizations, and they made it a little easier in the volume. But essentially what you're going to do is you're going to look at all of the encounters that you provided as a group, and then you're going to look at how many of those encounters were Medicaid encounters, regardless of whether or not Medi-Cal paid or was billed. Okay, so this is an update. Historically, you actually had to have paid claims, and Medi-Cal had to pay for some portion of the cost. So under the new 2013 rule, which went into effect on January 1st, you have the ability to basically just choose any encounter, regardless of whether or not Medi-Cal paid or was billed for the services, as long as it was a covered service. So dually eligibles are included in this now. And so, with the exception of Medicaid inpatient bed days must still be paid for in some manner, and that may apply to some of the organizations on here. So the high level and sort of simple version here of how to calculate the volume is take all of the encounters your organization provided in a 90-day period in a previous calendar year. So for 2013, you could pick the third quarter or the second quarter of 2012, a 90-day period. You look at the total encounters, and then you look at the Medicaid encounters, and then you come up with the percentage of volume. And another important note there is the one provider, one day rule on calculating the volume. So in other words, if you're having a provider that sees a patient multiple times on the same day, you only want to count that as one encounter. Now your billing system may count it as multiple encounters, and you may be getting paid if you, depending on your contract structure for those as an individual encounter. But for the volume calculation here in the meaningful use program, you need to consider those as one encounter. And we typically find that writing a custom report is the best way to establish this volume calculation. Most of the vendors are not providing this report out of the box because it tends to be pretty variable. So let me pause there. Any questions on the group volume?
No questions.
Okay. So once we have established the group volume in the clinic component here, in the group clinic practice, and we're going to also make another assumption here, and that's that you're only practicing in the state of California. If any of your organizations have practice or have patients that may be on both sides of the state line, you do need to put in additional information. But we're, again, making an assumption here that these are just California encounters. So you can choose then your encounter and fill out the forms, and then basically the system will automatically calculate whether or not you are eligible under the Medicaid volume percentage.
There is a question.
Yeah, sure, go ahead.
So one visit per day per provider is one encounter?
That is correct. Different providers, if the person sees different providers, then it can be counted as multiple encounters. So in other words, one provider, and there's one other caveat to remember here, is when you calculate the group volume, you're not actually calculating the EPs or the eligible professionals volume, right? You're calculating the entire group. So all credential types that provide services are going to be counted in this volume calculation, right? Because this is the total group encounters, regardless of credential or participation in the meaningful use program. And that's a point I forgot to make, but should be that I should point out. So then multiple encounters with the same provider on the same day can only be counted as one encounter. And that is, I think, the answer to the question the person asked. But different providers, same day, are going to be counted as different encounters.
Go ahead.
Okay. So once you establish that it is, in the state of California, necessary to upload a report from the practice management system or in a spreadsheet format that show how you calculated those encounters. So, you know, that's typically the point at which you can clarify your methodology for establishing the Medicaid encounters. And this is where, for example, if we, you know, show that a particular provider rendered 10 services, but that was all rendered on one day, we'll write the report to aggregate those as one Medicaid encounter. But we'll show the encounters individually underneath that provider on that day. So this report can get kind of long. But that is essentially the documentation that the state will ask for, and they also want a letter of explanation that explains how to interpret what you sent them. And I do know from firsthand experience that the better and more you know, clear that you are in this documentation and that letter, the better off you're going to be when it comes to the state essentially agreeing with your volume calculation. Because even though you may know you exceed 30% volume by far and away, as you probably also all appreciate, it's about your ability to document and demonstrate that in black and white terms that the state is interested in, because they are, of course, subject to audit by CMS and by Figliozzi and Company, which is the CPA firm that has been retained to perform the audits on meaningful use. And this is one of the core audit components, is verifying the accuracy of the group volume calculation. So once we've established the group volume, this is now where we are going to search for the NPIs of those providers that we completed the application for back at the NLR system, or the National Level Registry System at CMS. Because as you recall, we have completed 10 applications, one EP at a time. That database synchronized with the state database sent those pending applications down to the state level registry. You created a group clinic, and now you're going to locate the 10 providers by doing an NPI search that you want to associate or add to the group. And this is the process in the interface under step 3, where you're going to add those 10 EPs to your group clinic.
Rose has another question about encounters.
Okay.
Can I?
Sure.
Sorry, I'm not clear on the reporting of encounters. If our doctor saw 10 people in one day, is that one encounter? If our other staff see multiple clients in a day, do you only count those as one?
So yes, and let me sort of restate the question and make sure I'm answering it well. When you do the group proxy calculation, in other words, you're establishing your entire clinic's volume to which all of your EPs are going to be associated, you're going to use the same encounter calculation methodology regardless of the credential of the EP. And so, whoever saw a patient, the important thing is not the credential of the person that saw the patient. The important thing is the coverage of the patient that was seen, right? Because if that patient was a Medi-Cal covered patient, even if Medi-Cal didn't physically pay for the service, but was a covered patient during the time that you're running the report, then, again, in answer to your question, yes, if any individual saw the same person 10 times in that one day, that's one encounter. And we are not concerned about whether or not that was an EP or an MSW or a psychologist or a case manager. We're using the same volume calculation methodology for the entire clinic. And for those who have some specific or would like some more information on the volume, the volume calculation is a bit tricky, and so we may actually cover or choose to cover if there's enough questions on it, how to do that. And for those organizations that are using NetSmart, for example, we actually have already created some reports that do this calculation and line item these out, and I have some examples of how those calculations are performed and how the report calculates those in the formulas. So we do have very specific information available, but it gets a little bit granular for this presentation because it gets into the actual formulas in Crystal and SQL. But that said, feel free to email or request additional information on that because it is tricky.
One more question from Rose.
Sure.
Said if they saw the same covered person, that would be one encounter. But if they saw 10 covered clients, that would then be reported as 10, correct?
You are exactly right, Rose. So 10 different covered individuals equal 10 encounters, even if it occurred on the same day. And that's why the rule, the sort of, one way to think about the rule is one encounter per covered person per day. Underneath the individual practitioner, I should add, in the report. And that's where the report, looking at how we sort of structure these reports is helpful because you look at them per practitioner, per day, per encounter, right? And so then you have that data laid out and, essentially if there is a multiple encounters to the same person that are delivered under the same provider ID, those will roll up to 1. We zero out the others. But if it's under a different practitioner ID, then that gets counted. And yes, the report is a little tricky to write.
Says, okay, great, thank you.
Yep, absolutely.
Another question, where is the specific eligibility information for this found? How can I tell if our small county mental health agency is eligible?
And I think I need a clarification on that. Are we asking about specific eligibility underneath the group proxy volume calculation? And you could unmute that person if they'd like, and they could maybe ask it.
Crystal, I'm going to unmute you.
Hi, Crystal.
Oh, I have to send the audio pin in order to enable muting because she hasn't. I'm sending you an audio pin, Crystal. Oh, well, now she typed another question. No, for the general program, she says.
So the answer is yes. There is information on eligibility, and it is on this website for those that can see my screen. And I think everybody can. Can you see it, Shoshana?
I can, yeah. I mean, I
okay.
can't read it. It's too small, but there.
So these webinars, unfortunately, don't work, but the downloadable resources here under Provider and under Group Clinic will help. And the sort of straightforward answer to how do you determine if you are eligible, again, is you're eligible based on a combination of essentially three very sort of straightforward factors that sort of have some nuance when you drill into them. In other words, if you have a certified EHR, check. You could be eligible. If you have EPs that work for your clinic that see Medicaid clients, you could be eligible. Check. If you, as a group or a clinic, see at least 30% Medi-Cal enrollees underneath the volume calculation methodology that we just reviewed, then you could be eligible. Check. If you can check all three boxes, the answer to your question is you are likely eligible. And with that, we get to the EHR documentation. Okay, so this is one of those prerequisites to eligibility. And that's back where, as you review the slides in the beginning, before we sort of charge down this path of setting up, federal NLR accounts and setting up state group proxy accounts, we generally like to establish with a relatively high degree of certainty that your group or clinic is eligible. And that's where we typically do an analysis in advance of the overall practice setting or practice setup, I should say, at which point, generally we come out of that with a percentage of likelihood of eligibility that we believe your organization, would have, for example, a 70 or 80% chance of having eligibility for X amount of EPs. Because that's the other challenge with the way this program was set up for behavioral health, right, is that it's actually a combination of group and individual eligibility, which create the ultimate answer to your question of whether or not your group is going to receive money and be eligible. So that said, you do need to obtain your CMS documentation here under your EHR certification ID. That number there, the 300000, etc., and even TMK, QEAS, that is the number that you can get when you go to the Certified Health IT Product List website. Search for your product, and then generate that number by placing your product in the shopping cart. And this is the information that you will need to upload to the state system to verify that. So back to our group express attestation process, and we're almost there. This is now at the end of the line here, as it were. You've done your federal applications. We're down into the group clinic. We've done our volume. We're at the end of this process, and now you have a group express attestation that you can click, and that will create, if you had, for example, 10 EPs that you're associating in your group or clinic, that will create 10 forms. And you can then print out those and have one more signature now to obtain from your EPs for your audit record, which will then complete that process of having all the information, the group volume calculation, the permission for the EP to use their encounters as part of the group. All of that will be contained within there. That can be signed and placed in your audit documentation folder. And then you are essentially through the 5 steps. And those 5 steps in review again about your group, the group clinic, the managed providers that we talked about. This is the EHR technology and group statement step that we just covered, where you're going to upload that documentation from the federal site that proves that you have a certified EHR. And now that you're completed with that, you've got all of that signed, you are going to submit your application. And that equals, hopefully, success and the completion of your AIU phase of the program. So with that, we've essentially covered quite a bit of ground and got some great questions along the way, but I want to encourage anyone with additional questions to send them our way at this point.
Nothing yet. Here we go. What is the whole purpose of the Meaningful Use Program?
That is a great question, and I have a slide in there for that I was worried I might not get to. So let me answer it at kind of a high level. Really, there's a couple of key components to it, and here, let me actually pull something up while I answer it. But the overall objective is to encourage the adoption of electronic health record systems. But there's actually a couple of 5 specific steps or particular components that CMS is interested in. And so really the first objective is to improve the quality, safety, and efficiency and reduce healthcare disparities. And so the objective there is to implement technology that contains clinical decision support rules and triggers and alerts, e-prescribing, contraindication flags, right? And these features are built into the EHR systems that are certified under meaningful use. Another really important step is to engage patients and families. And we start to see these particular components play out as we get into the second stage of the program, right? And so underneath stage 1, you're going to see some measures which relate to patient portals. And you're going to see some components of EHR systems and options that allow, you know, the electronic health record to be shared with your patients when clinically appropriate. And admittedly, there are a number of different things that are relevant to mental health agencies when it comes to sharing information, and we certainly appreciate that within you know, the context of permissible information is probably the best way to look at that. Given the 42 CFR Part 2 implications for some providers, we of course do need to be mindful of what we share and how we share it. So the third objective is improving care coordination. So really we want to look at the measures now in stage 1, which we're going to get to in our subsequent presentations, which deal with submitting a CCD file or a continuity of care document to another hospital or system that contains components of a patient's record on some type of exchange. And that's where there's some initiatives going on at the state right now, including a feasibility study of the short Doyle system and looking at some architectural, basically looking at some architectural and redesign opportunities. There's some other initiatives at CIMH that are happening related to sharing information between providers on some exchange-type products. And there's a state exchange and Medicity exchange out there. So again, these all relate to care coordination. I'm looking to improve population and public health, which is where you'll see some measures related to syndromic surveillance, for example. And that means basically submitting diagnostic information related to certain diseases that might be flaring up, if you will, in a certain area of the state or of the country. And that's looking at having your EHR system automatically submit to the state public health department what's called the ADT A01 message framework, which is the admit, discharge, transfer HL7 syndromic surveillance file that carries that information to the state to tell them if there is a whooping cough outbreak happening simultaneously around the state. So that, for example, is a requirement of the stage 1 reporting period. You have to test your system's capability to produce that file and send it to the state. And a fifth and important component of this is the ensuring privacy and security, because embedded in the meaningful use incentive program is a requirement to perform routine security audits and ensure that both your EHR system, as well as your policies and procedures, as well as your servers and your systems and your laptops abide by particular encryption and safety standards relevant to protecting that information. So that is, at a high level at least, the purpose of the program.
There's a question, where can the CMS registration disclaimer be found? Is there a link?
There is a link in, let me see, I may be able to provide that. It's found at the point at which you submit an application for one of the providers. So if you're acting as that third-party registrant, that's when that comes up, and that is something that we typically encourage organizations to use. We typically combine that with a either a contractual or an audit statement that is then also combined with the express attestation for your state. So it's sort of a combination of things, right? It's the CMS agree, accept, submit process. It's the state process. And typically we kind of custom put that together, if you will. But I will follow up with some example language that will be relevant for the state here and for the counties and agencies in California. And you can refine that as it's relevant for your own organization.
Is the benefit viewed as taxable income to the EP? So who would pay the income tax?
So this is where I get to say we're not a tax professional, and therefore we don't offer tax advice. And the reality is that when you reassign the benefit to the organization from the EP, the organization is who is receiving that income. And so there is, only a tax relationship between those who received the income and the IRS. So that's sort of my roundabout way of saying that historically there has not been, any tax implication for a EP who reassigns that money, but you do need to talk to tax professionals to look at your own individual circumstances as an agency to see what the impact would be of additional income at your agency.
How can an encounter by an MFT who is not an EP be calculated into the EP number?
If you are using the group proxy calculation model, you are using the encounters of every clinician in the group regardless of what their credential is or their participation in the program. Now, if you're just going to use a one-by-one calculation, EP by EP, then you're not using the group proxy model. You're doing individual applications, and you're essentially having each individual stand on their own in the application process. And in that case, you don't utilize anyone else's encounters to establish the volume. You just have a different volume calculation for each individual EP based on only their encounters, which amounts to having 10 different volume calculations, one for each individual EP. Where under the group, we do just one, and we count everybody's encounters regardless of their particular credential or participation in the program.
Doesn't look like there are any other questions. Wait a few more minutes.
So I do have a question for the audience, and you can just show it by a show of hands, or if you'd like to talk about it, you can as well. How many organizations are planning to do the stage 1 90-day period this year still? And I think there's 4 to choose from, so I'm kind of addressing the 4 that have historically done AIU. Are any of those 4 planning to still try to do stage 1 this year?
Looks like 1.
Okay. And then for the broader audience, how many organizations on today, of the 22 that are on presently, are looking at trying to do the Medicaid AIU program in 2013 still?
Like 2 at this point.
Okay. So the others who are maybe not answering or not sure or on the fence, maybe a question that you could follow up with Shoshana, with is, what are your barriers to doing the meaningful use AIU? What do you need more information on in order to be able to approach it? And or, is there any topic in particular that would help you be able to achieve that, that you'd like us to address? And of course, the answer might also be you just don't think you're eligible, or you don't have EPs, or there's something else you learned today that makes you wonder whether or not it's worth your time, effort, or energy. So several things to choose from, but I would ask that of the audience, so that when we determine the content for the next webinar, we have an idea of what the best content is for the audience. We will, be doing a stage 1 program here shortly as well. And I'm curious, for those that are doing stage 1, what EHR system are you using for the organization that said they're going to move forward with stage 1 this year?
There is another question, however.
Okay.
Must a privacy and security risk assessment be completed for eligibility?
The privacy and security audit needs to be done underneath the stage 1 90-day reporting. It does not necessarily have to be done before you complete the AIU process. So from a regulatory perspective, an agency is not asked to upload information attesting that they've had a security audit underneath the AIU process we just walked through. They will be asked to attest to that in the stage 1 90-day reporting period documentation upload.
Any other questions? I think that's it, Beth.
Okay. Well, great. Well, thank you everyone for staying on here, and I know that it's a long day and a dense topic, but certainly appreciate any feedback you have, and feel free to email Shoshana with suggestions and to help refine what our next content and presentation can offer so that we can be of help to all of you. Have a great afternoon.
And we'll send out the date of the next webinar as soon as we have it.
Great. Take care, everyone.
Bye.